Joining me right now is ACMC segment is Dr. Let me Bibidakis, and your first name is Evangelos.
Yes.
Is it? You've been on the show before.
Yes.
I remember you now after I've seen you here. Now, doctor, tell us what you do at the hospital.
Yeah, it's so nice, first of all, to be back. It has been about 6 months. New things have been added to the ACMC armamentarium, technical and regarding personnel and procedures. So we have a new mammogram device, we have a new MRI, and we have new equipment in the OR that help us doing more stuff. Also, new physicians were hired. For example, in the Department of Surgery, we have now Dr. Kim, who's doing more vascular stuff, and the type of procedures that we're doing expands more. I'm coming back to what's my field of expertise. What I was trained back in Philadelphia and in other places in the United States to do is mainly oncologic surgery, which has to do with cancer, and minimally invasive stuff. This is the type of operating in the body without doing the old traditional type big incisions. We can explore different cavities of the body, like the stomach, the abdomen, the chest, without making these big incisions. 2 or 3 small holes, and we can have access to most of the organs. The benefits are obvious. Less pain, easier and more detailed procedure because you do surgeries under high magnification, faster recovery, and sometimes better outcome results. That's the first portion of my expertise. The second one is the oncologic surgery, as I said. The treatment for cancer has evolved the last decade, and we tend to go from the big amputative type surgery to more sophisticated and detailed approach to cancer. This way you have less complications, faster recovery, but also the patient can go quicker to the next phase, which is the chemotherapy or radiation treatment. A big procedure was delaying the treatment, delaying the recovery, making the results sometimes worse. And now we're coming to the merge of the two techniques, the minimally invasive and the new techniques in surgery. Let me give you an example and leave from the totally theoretical type, university type of lecture. A patient who comes with a nodule on the lung, the old days we had to crack his chest open and make a big incision from his back all the way to the front to approach the lung to get a biopsy. Nowadays we have the bronchoscopy where we can go through his throat if it's close to the heart, the lesion, or if it's in the periphery, we make 2 small incisions between the lungs and we can go and remove the lesion. We have about 50 patients since we started that technique here in Ashtabula that were treated this way. They had either complete lobes resected or tumors resected from their chest. The patients were back at home in 2 or 3 days. The old technique.
No, excuse me, can I? Yeah. So you're actually have gotten away from the major cutting.
I would say in a percentage of about 60%, yes. Still, sometimes we need the big incisions.
Yeah.
And although our training, the initial training was to learn first the extensive surgery and then go to the minimally invasive, to the more delicate procedure, I would say in about 60% of the cases we have gone away, yes. And we're able to resect the same way tumors in the liver, tumors in the colon. The colon actually is the routine. I would say probably 90% of the colon cancer nowadays is being done laparoscopically. We don't open the abdomen. I had a lady about 2 weeks ago in the hospital that I removed. She had a different type. It wasn't cancer, but still, I can show how extensive the procedure can be done through the laparoscope. We removed 4/5 of her colon for really bad constipation that she had in inertia of the colon. The large bowel had become a big bag that was holding stools, and she was going to the bathroom once a month. And the lady went back home in 2 days, and she has been relieved from her problem. She cannot believe the fact that she can eat foods that they were totally prohibited before.
Really?
And that's with 4 small, tiny incisions, about half an inch each of them.
So you can do this here, Doc? You can do this right here?
Yes. That when I started on my introduction talking about the new equipment and stuff, it's a lot of things that were purchased by the ACMC and invested in that. Let me give you an example. When you get into the abdomen, you can see inside the cavity directly. Now we have a scope that you can look from the side. You can approach it from different sides, and you can essentially see everything the way you see it when you open. Plus, the fact that sometimes you inflate the abdomen and you are inside the abdomen, the gas that you put dissects the tissues and it creates you a clear field. Another thing, the laparoscope magnifies the things about 8 to 9 times. So that means you see them in higher detail. So everything is more beneficial. There are some problems with the technique. Everything is improved, and as you get more experienced in the field, you bypass all these problems. One is the tactile sensation. Like, you don't have the chance to feel the tissue. As the experience increases, you may feel it with your forceps or clamps. But the bottom line is you can do things that were unbelievable the old days.
Sure. You know, it's amazing to me, and I don't think people think about this. You learned a certain procedure as you started out as a young man, as a doctor, and then as time goes on, you've got to learn the new techniques. So what do you have to do? Do you have to go back to school for that?
All the surgeons in this country, they have to go through the continuous educational process. In order to certify for the American Board of Surgery, we have to accumulate certain credits, CME credits. These credits some of these credits should be coming from the field of expertise. So if I'm a minimally invasive surgeon or an oncologic surgeon, I have to be trained further and get these credits to qualify for the next exam. So most of the surgeons, they have to do it. Always there are ways to avoid that, but this is something about trying to help people, and you try to find things to do your surgery more effectively with less pain and have more happy patients.
Mm-hmm. So what a changeover. I'm simply amazed. I didn't realize they had all this technology.
Yeah, and actually ACMC invested on doctors, invested on equipment, and now we have other things, other plans in the future, and some things that they are being developed now. As an example, it's the head and neck surgery. We have an ENT physician, it's me, and it's also Dr. Kim, who are dealing with the neck. Big thyroid tumors, parathyroid disease, big neck problems with lymph nodes or oral cancers now can be treated at the ACMC.
Really?
Yeah, this is a little bit more extensive surgery, can be done with small incisions, and we can have great results.
Where's the thyroid at?
The thyroid is located at the lower part of our neck. It's shaped with 2 lobes and an isthmus that's connected in between, and it has to do with our metabolism.
And that's what it's for?
Yeah. So even the old days, to see how important it is for the metabolism, there were diet centers who were given, they were trying to increase the metabolism by giving thyroid hormones. It's not the right way of using this medication, but I mentioned because it was known since the old days how thyroid functions. But what we're dealing with is hyperfunction, hypofunction. That's mainly a work of the endocrinologist, and then the tumors of the thyroid. tumors, the cancer of the thyroid, now that people, I guess the average level of radiation in our environment has increased. And a lot of people are being exposed to radiation for medical reasons, for other reasons. And the type of cancer that we see nowadays on the thyroid, the incidence of cancer on the thyroid has increased. And it's a type of cancer that if you treat it, if you attack it early, the survival and the cure is close to 100%. So it's worth, when somebody feels something on the neck or has a problem in the neck area, to visit the primary doctor, and if needed, he or she will be referred to us.
Very good. Yeah. Very good. I just got a memo for you. This is from the hospital. Please ask Dr. Bibidakis about his appearance with Dr. Vargai on October 19th at the Ella Club?
Yeah, a club in Ashtabula.
Ashtabula. Luncheon presentations by cancer specialists, vendors, ACMC exhibits. For more information and to RSVP, the number is 997-6555. Can you fill us in on that?
Yes. We will have that luncheon where Dr. Vargai, me, and usually there's another person who's invited doing mostly research on cancer. We will present the most recent advances on cancer treatment, and it's going to be held at the Elks Club that's on Lake Avenue in Ashtabula.
Oh, the Elks Club.
Yeah, the Elks Club.
Okay.
And it will be very interesting. And if somebody has questions, then we can discuss them either in public or in private. We have the chance to interact with the community, present the latest data, what we do in the hospital, and we can go over things that sometimes people have the questions and they don't have anybody to ask them.
Sure, yeah. Sure. Have you done any of the dinners with the doc yet?
Yes.
Have you?
Yes.
Those look like they would be fun.
Yeah, they were nice. I had people who asked questions that never thought about, and this direct contact that you have with the patient in a relaxed environment sometimes helps you to describe things and go over complex issues in a more relaxed way.
Sure.
And explain things. So a lot of people understand.
I understand it's a really relaxing setting, you know, because you get a chance to go one-on-one with the doc, and normally you don't get a chance to do that. So I think that's good. I'm sure you know this. ACMC is opening a facility here in Conneaut.
Yes.
On the west side of town. I'm looking forward to that.
Yeah.
And I got to meet your new doctor, Dr. Rufo.
Mm-hmm.
And what a great guy.
Yeah.
He's going to start coming on the show on a regular basis, from what I understand, and he's a lot of fun. He's a good doctor.
Yeah, he's a very nice person. I had the chance to meet him when he first visited the ACMC, and then after he started, he's very dedicated to his patients. And I've realized from the referrals that he has sent me, all these things, the peripheral, everybody may like a person, but what comes to the bottom line is how good doctor he is. You want this human contact, but you want him to have the skills and the knowledge and sometimes the manner to treat the patient. And I've realized from patients who were referred to me from the Conneaut area by him for different problems. He's specific. I would say 99% of the time he's right on what he describes, and most of the times in my notes I have to add almost nothing. It's like I'm copying his note to my note, because it's exactly and precise on what he describes. His diagnosis is very accurate, and I'm very glad that we have it.
Yeah, that's a good addition, good pickup. He actually said that he's not beyond even listening to holistic medicine, because I guess his wife's a pharmacist and believes in that kind of stuff. He goes, I'll listen to that if that's what you believe in. He goes, I can work with you on things. And what was kind of neat, he goes, he's in his 50s now. He goes, I'm here for the duration, so I'm not going to be leaving you, and which has been happening here, where doctors have left, and then we have too many patients,
Yeah.
So I think it'd be a welcomed addition to this community.
Regarding the holistic medicine, I have no objection, as long as you don't leave the traditional treatment.
Right.
Yeah. And there are problems sometimes. I'm leaving from the field of surgery, but like for example, there are patients who are suffering from headaches for many years. You cannot keep getting pain medication all the time. And there may be treatments or ways to help you in this case. Why deny that? But I wouldn't agree with a patient who has, let's say, breast cancer, and you realize that needs extra chemotherapy, and they say, no, you're not going to get any treatment. You're going to go just and get these herbs. Mm-hmm. You know that this patient, based on studies and different other, and I had patients like that. There was a lady who left from here, went to Alabama to get involved in a treatment, and I know she's not going to have a good luck there.
Yeah.
We have Dr. Vargai in the Oncologic Center here in Ashtabula, and they are doing an outstanding work. And we're assisting them on what they want, and patients are cured from cancer. And I'm coming back to that because holistic medicine and what we said about Dr. Rufa is good as long as you don't forsake the traditional.
Right, exactly. And I think he stressed that as well. I know there's a movie actress, I'm not sure if you're familiar with her, named Suzanne Summers, who came down with cancer several years ago, has written a lot of books, still alive, but she went into this, some kind of, I'll use the word holistic, I don't know whether that's the answer or not, but she went into this thing where she did her own treatment, and she's still living. That doesn't seem possible to me without the right medical procedure here.
In general, in practice of surgery, how we evaluate the results sometimes, what we say is a certain treatment has effect based on the 5-year survival. And we know that the average type of cancer, if you have a recurrence or it develops a metastatic disease, usually that happens in 5 years. Now, what happens? When you hear a patient with extensive cancer, the possibility of 5-year survival may be 2% or 5%. So out of 100, you may have 2 who, for unknown reasons, without any treatment, may survive.
Really?
And they have been described cases, especially with melanoma, that there was sudden regression of the disease. Somebody may call it a miracle, somebody may call it something else. But don't think the 1%, think the 99 or 98 who will die in this case. Mm-hmm. And that's what I want to say. I understand that some people may were lucky or may not have revealed the whole truth, may have some additional treatment, or there may be any other factor that we don't know. So in general, medicine doesn't make comments on the curability of certain cancers based solely on a single patient. They make with studies that they are double-blinded. Whoever studies the results doesn't know who the patient was before, and the patient who provides the results doesn't know who will interpret them, and then comes to a conclusion that has a population with statistical significance.
And I'm sure that when you do this presentation on October 19th, people will be able to come up and ask you about all these procedures that you can do.
Oh yeah.
That you do here at ACMC.
Yeah. I want to say, at least from my side, it will be focused on the treatment of cancer. It's not going to be an extensive lecture. I will describe, though, one by one, the newer treatments that we have at the ACMC. Then, whoever wants to ask questions can ask the question. Now, there is some sort of privacy with this kind of problem or disease, so somebody may want to talk to me in private. There is no charge, it's not friendly. They can come to me and we can give like first advice or see if they need some further treatment or diagnostic workup, and I'll advise them based on their problems. So they should feel free to come and ask questions.
And Dr. Vargai is a cancer doctor?
Yes.
Also? Okay.
He's the medical oncologist. I'm the surgical oncologist, doing mainly the resection of the tumor, doing the surgical, either minimally invasive or open. I'm doing the first stage, which is usually the resection. The second stage, we know that the main tumor may have sent cells, peripheral cells, to other tissues. There is no way to see them by naked eye. You gotta give substances, medications, treatments that will chase these cells that they have gone in other places of the body and kill them. So he's doing that second portion, which is equally effective and sometimes even more important for surgery. For example, breast cancer nowadays, we believe the major advances that we have are based on the chemotherapy. We do less and less aggressive surgery. Simply, nowadays, somebody who comes with breast cancer gets a small incision with resection of the primary tumor, a small incision in the axilla or through the same, and we remove one lymph node. It's called sentinel lymph node. We're going to do the old type procedure, which were very amputative and emotionally stressing for the women.
Do you have regular office hours, Doc, or
Yes.
do you have a special day for surgeries, or?
In general, I operate every day. I try to see my patients in the morning. I have afternoon office hours as well, but I operate any day and always have gaps on my hour schedule because there are urgent cases that may come in between,
Right.
and try to serve the patients based on the urgency of the case. For example, if somebody is bleeding from the bowel and has a lesion there and needs to be removed, cannot wait the same time period as somebody who has a hernia. So we space them out and we rearrange the program of your schedule and our schedule continuously in order to provide the best care for every patient.
The reason I ask is because a lot of people have emailed me over the years that they want to be able to sit down and ask questions. They have concerns.
Yeah.
And do you have time for
Yeah.
that?
And actually, when somebody comes for the first time, we devote almost 2.5 times the time for the patient who comes for the post-op visit. We want to answer questions before somebody goes to surgery or asks for our expertise, and spend time to explain everything that they need, the way we plan to proceed, and what's needed for the problem. So I would say the average person who comes post-operatively, we spend 20 to 30 minutes. The person who comes for the first time, we spend even 1.5 hours. I had a patient, yeah, because they may have a lot of questions, so we're there to help them.
That's fantastic.
Yeah, they're going to find us up in Ashtabula Clinic. The surgery offices are on the 3rd floor, and I can give the number. It's 997-6960. Whenever they want, they can call and ask for the doctor they prefer.
Very good. This is not your expertise here, Doc, but this gentleman has a question. I'm going to throw it at you, okay? Do you know, Doctor, what bundle branch block is?
Yes, oh, absolutely.
Can you explain?
Although it's not in my field, as from the knowledge of the general medicine, or especially for this question, cardiology, that's in the field of cardiology, we know the basic principles and the basic problems. Now, the heart works in a very sophisticated way. It has a circuit that transmits the stimuli to the muscle, so it contracts in all together, and you don't have one ventricle contracting while the other is relaxing. You are successful on that with a circuit that's called the bundle branches. We have the major node, which is in between, in the middle of the heart, and there are 2 branches that emit the stimuli. One of them is the right, the other is on the left, based on the ventricle that they go. Sometimes, as cells degenerate and die, or if somebody has a heart attack or has any other problem, an infection in the heart, various other reasons, one of these circuits may start malfunction or may not work at all. So stimuli are not being transmitted the usual way. Always our body has ways to bypass the problems. So the major thing is you see a change on the EKG. It doesn't mean by itself that it's a major problem, but if you get problems in both bundles then there may be a problem with the speed that the heart works. So in case the cardiologist thinks there is a problem, then in more advanced cases, if it's a simple bundle branch block, you may live your whole life without problems. If both bundles are affected, then the cardiologist got to think if he's going to treat the patient with medication or in some cases with a pacemaker.
Pacemaker?
Yeah, because it replaces the non-function conduit system.
I believe this person, he sent me to on this, and I believe he said that I thought he said that his heart was 30%. Does that mean 30% active or working?
Yeah, I cannot, there are a lot of possibilities. If he had an MI, it could be 30% of the muscle that may have died. If it was function-wise, it's what we call the ejection fraction, and sometimes the ejection fraction of 30% is a low ejection fraction. The average for a healthy person is close to 60%, 60 to 70. Always there is, the ventricle on its squeeze cannot push all the blood out. It pushes about 70%, 60 to 70%. If it's pushing 30%, that means you have stagnant blood, you have enlarged heart, you have, it's not working as it's supposed. And when you're sitting on a chair doing nothing else, it may not be a problem. But if you start walking or doing something that's more demanding, you may have a problem because you need higher output from the heart. And 30% heart may not fit on the requirements that you have. And that's where you develop the failure.
Thank you. Thank you for explaining that. I hope that answers your question, sir. Doc, I want to thank you so much for coming in. Very educational segment this morning. Glad to have you here. Could you give your phone number one more time?
Oh, yes. Whoever wants to visit us, you can find us at Ashtabula Clinic on the 3rd floor, and the number is 997-6960. And I'm going to say it again, 997-6960. You can ask for Dr. Bibidakis. I'll be more than glad to see you and discuss with you and go over the problems. As I said, the field of expertise is general what has to do with surgery. Even if it's not in my field that I'm specializing in, I will direct you to the right person.
And don't forget, Doc and another doctor, Dr. Vargai, will be at the Elks Club in Ashtabula on October 19th. And to give you a chance to meet him, and they're having a luncheon, presentations by cancer specialists, vendors, ACMC exhibits. And for more information, you can RSVP. They are asking for an RSVP at 997-6555. 997-6555. That'll be interesting as well. Doc, thank you so much.
It's my pleasure being here, and I look forward to come back and answer questions, discuss, and go over new topics.
Please do.